Hello everyone, and welcome today to this audio podcast. This audio podcast is part of the conglomerate. This audio podcast is part of a Labostic storm. This audio podcast is part of a Storm and Battle and Chronicle. This audio podcast is part of the Stormish edition or series, and this audio podcast is part of a Storm Labostics production. Through this audio podcast, I look at through this audio podcast today, looking at sort of a look at laboratory investigations, biomarkers, and biomarkers, and biomarkers. This audio podcast is in amongst a in amongst in amongst the Squalish series or edition, but for the purposes of the importance of the backdrop to the to the outline of the audio podcast. It is where this audio podcast, as part of this Stormish series and edition, will look at this entity again. So to begin with, a look at a chronic kidney disease, or CKD. So chronic kidney disease has five stages, and each stage has an interlink with a severity. So stage one, for example, is where there can be renal damage, and where GFR, glomerular filtration or rate, is identified as more than 90 mils per min per 1.73 meters squared. Stage 2 is where there's renal damage, and whether GFR is normal or raised, and can be 60%, 60 to 89%, 60 to 90, 60 to 89 mil per min per 1.73 meters squared. And then in stage 3, stage 3 is where there's moderately reduced GFR, where it's 30 to 59 mils per min per 1.73 meters squared. In stage 4, there's severely reduced GFR, 15 to 29 mil per min per 1.73 meters squared. In stage 5, there is end-stage renal disease, or ESKD, ESRD or ESKD, end-stage kidney disease, and where GFR is less than 15 mil per min per 1.73 meters squared. In as a part of the initial laboratory investigations, routine biomarker referred to as, or known as in amongst the literature, is creatinine, or has been creatinine, to determine renal insufficiency. Creatinine is a byproduct of muscle breakdown and excreted by nephrons and filtering components of the kidneys. The normal range of creatinine is anything between 60 to 120 micromoles per liter, although in laboratories the reference range, or in around the parameter, varies from different laboratories. When kidneys become sort of when a renal pathophysiology becomes affected, the creatinine biomarker is evidence that shows that it increases up to increases, and thus where renal function becomes compromised. In around the creatinine levels may creatinine levels may be either very high or very low in early stage, or in early CKD stage, in early CKD diagnosis and staging. In around estimated glomerular filtration rate (eGFR). eGFR is a clinical standard to determine an estimation of renal functional in around renal pathophysiology. eGFR is used for the determination and staging of CKD. Excuse me. eGFR equations are used or utilized to determine renal insufficiency and renal filtration through the use of biomarkers. Which are used in conjunction, which can be used in conjunction. So, for example, there is literature to inform. Excuse me. That there has been literature to inform in around the use in combination of creatinine with cystatin C. In amongst sort of laboratory investigations. A quick look now in around BUN or blood urea nitrogen. So urea is a molecule produced is a molecule produced from where urea or toxins from the blood that are aligned to a urea are excreted by and through the kidneys. The level of urea the level of urea in blood rises in amongst renal insufficiency. The amount of urea can be affected based on a number of variables. The value of urea can increase in around dehydration. For example, the normal value in around urea is for example is and has been in literature in around 2.5 to 6.6 mil per mole per liter, according to the general population. Urea is accumulated in blood in amongst blood in CKD and it is an accurate investigation for renal function, but it is more useful when utilized together with creatinine investigations. I look at potassium. So potassium comes from varying forms of sustenance. Potassium rises in people with renal insufficiency. Potassium levels can rise with some pharmacotherapeutics, and it can be dangerous when kidneys do not function adequately, or where there is renal insufficiency. If potassium levels are high and a renal insufficiency is evident, a form of KRT or RRT is and can become necessary. Normal range in amongst the population is anything between 3.6 and 5.0 millimoles per liter. In around sodium comes primarily from salt. It increases with when renal insufficiency where renal insufficiency is evident. Increased sodium can cause anomalies in around ABP. and sweat in addition with fluid retention, and where the fluid retention affects the general pathophysiology. Diuretic medication sort of increases sodium sort of output in through urine. However, is sort of used sort of less so as or diuretics are used less so sort of as part of more recent in more recent practices, owing to how particular components of renal pathophysiology can be further implicated. Most renal recipients most renal recipients are informed to have less salt, for example, and many evidence has, as well, literature has informed that literature informs or has highlighted that that recipients that some recipients may be on where recipients may be on diuretics if if it helps in around particular aspects of renal kidney conditions. The normal value in healthy population is anything between 135 to 145 millimoles per liter, and when there is a renal insufficiency, the sodium rarely changes. In around a look at anemia. So a reduction of blood hemoglobin, or HB, concentration is a common issue in CKD. In CKD, it is present when blood hemoglobin concentration is reduced to levels below that necessary to adequate tissue oxygenation. Anemia is investigated in recipients with CKD when HB levels fall below when HB levels or hemoglobin levels fall below, for example, anything sort of less than 11.5 grams per deciliter in adult females, 13.5 grams per deciliter in adult males, and 12 grams per deciliter in adult males over 70 years. Amongst the literature in amongst the laboratory reference ranges may well have more may have more updated aspects in around the HB levels in amongst different populations with CKD. Additionally, anemia is a well-known complication in CKD and associated with progression with CKD. Excuse me. Where there is CKD progression and poor quality of life, and an increase in morbidity and mortality. The mechanisms or mechanistics of anemia in CKD are multifactorial, and can include where there is deficiency in around deficiency in around the hormone erythropoietin, where iron and where anemia is evident is where there can be sort of iron deficiency. There can be various pro-inflammatory mediators commonly elevated in CKD, which may affect erythropoiesis in CKD recipients, and it can be uremic induced inhibitors of erythropoiesis, and shortened erythrocyte survival or prognosis, and disordered iron hemostasis or homeostasis is and has been documented in amongst the literature. At the same time, anemia increases progressively in and where the EGFR declines, and anemia is associated with poor outcomes, including higher mortality in recipients with ESRD or ESKD, and in those with non-dialysis dependent CKD. The prevalence of anemia is high. Is high in recipients with non-dialysis CKD, and increases as CKD progresses, being present in approximately 42% of recipients with CKD stage 3, increasing approximately 76% to 76% in CKD stage 5. So now looking at in around iron deficiency. So iron is essential for many important biological reactions, including oxygen transport or transportation, cellular respiration, and DNA synthesis. Systemic iron balance is maintained by regulating iron absorption and iron release from storage sites in amongst the liver. CKD recipients have increased iron losses, or can have increased iron losses, estimated at 1 to 3 grams per year in NKRT or RRT recipients, due to bleeding or chronic bleeding, where chronic bleeding is evident, and from urea-associated platelet dysfunction, from urea-associated platelet dysfunction, and frequent phlebotomy and blood trapping in amongst dialysis or KRT or RRT apparatus. And that draws this audio podcast to a close. This audio podcast as part of the conglomerate. This audio podcast as part of the Laboratory Shitstorm. This audio podcast as part of Storm and Battle and Chronicle. This audio podcast as part of the Ztormish. This audio podcast as part of a Storm Robotics production.